Hello and welcome everyone for tonight's EAO session, Just Ask. Again, we're back on the first Monday of every month, just before summer break, remember that? And tonight, it's just an amazing pleasure. I have a very, very, very special guest tonight, which is Ausra Ramanauskaite, and you won't believe it. We have Tomas Linkevicius from Lithuania. We have the next superstar from Lithuania. Guys from Lithuania, what are you doing? Where is all the brilliance coming from your country? Ausra, a very, very warm welcome to you.
Thank you very much, Stefan. Good evening, everyone. Thank you for such a nice introduction. Yes, I'm super excited to be here in this live session this evening.
Yeah, it's just amazing to have you, not only from a personal perspective, but also from a professional perspective, because you are one of the top experts for peri-implantitis. Just very briefly to your CV, I think everyone knows you. I think there are already a lot of fans logged in for you. We have people from Spain. We already have people from Uganda logging in. We have people from France, from Albania, Moldova. So amazing, all the people coming for you, Ausra. And you did your dental degree in Lithuania. You actually just learned you're also a periodontist, and which is very nice because I am always the one and only periodontist here. And then you came to Frankfurt, you did your oral surgery, you did your PhD, you just finished your habilitation here in Germany, which is the top-notch scientific thing you can do here in Germany. And you are an international speaker. You just had a horror trip behind you. So we're very happy that you're here. And again, very, very, very thank you also on behalf of the EAO for accepting our invitation.
Thank you very much, Stefan. Really my pleasure.
Ausra, tonight the topic is peri-implantitis. And, you know, I knew I'm going to have you as a guest. And I just did surgery on a case. And I thought, what would Ausra say if she would stand behind me? And I flapped it open and look at that clinical picture. What would you whisper to me if you would like stand behind me and look over my shoulders? What would you tell me? Should I do an implantoplasty? Should I regenerate? Should I do resective regenerative? Or should I take it out? Just your 2 sentences on my case.
Well, Stefan, in this case, so we have an implant in an aesthetic area. And in this case, it is not only about the treatment of inflammation, it is also about the aesthetics. So, of course, I would go for a surgical treatment. And as I see, you have a combined defect. So I would go for a combined treatment. And this we will go in depth during my presentation. So combined treatment would be the treatment option for this case. But
so there's
also another aspect of aesthetics.
Okay.
We can all discuss.
So I'm happy because I did that. I did a combined treatment. So you would probably say, okay, Stefan, go on like this. I did implantoplasty on the dehiscent area, but I want to know from you if I also should do that in the supracrestal area of the defects. Maybe we will discuss about that later. Ausra, we want to get your knowledge now because I know you're such an expert. You did so many studies, nice clinical studies. We have also a lot of people logging in. Hello from Norway, from Kenya. Wow, all around the world, people are coming for you. So I know you prepared some slides for us, and I'm eager to hear these slides. And we always do it like we always do it here. If I have a question, if a question pops up, I'll just interrupt you. It's not unpolite. It's just because it's nice to have an interactive discussion. Please, Ausra, your presentation.
So, Stefan, yes, indeed, I prepared a presentation which aligns with the current EAO position paper on the treatment concepts for peri-implant diseases. So, those are the clinical cases that I'm sure all of us have faced in a daily clinical practice. bleeding in implants, increased probing depth values, suppuration at dental implant sites. And the question is, why should we talk about the peri-implant diseases at all? The thing is that if we take a look into the prevalence data, we would see that every second patient, so half of our patients with dental implants over the time are diagnosed with mucositis, and almost every fifth patient is diagnosed with peri-implantitis. So every fifth implant that they place is likely to develop peri-implantitis lesions. So the numbers are huge, meaning that we need to know how to diagnose the disease and how should we treat the patients with peri-implant disease. So first of all, we very clearly know that peri-implant diseases are bacterial plaque-induced pathology. So we are treating and bacterial plaque-induced inflammation. On the other hand side, I will not go too much deep into the risk factors for peri-implant diseases, but we need to be aware of a fact that not only the bacterial plaque plays a role upon the onset of inflammation, but there are also local and patient-related factors that contribute to the onset of a disease. For instance, periodontitis, untreated periodontitis, the shape of a prosthesis, accessibility for oral hygiene measures are crucial parameters that we need to evaluate before we start with the treatment procedures. Because if we ignore the local or patient-related risk factors, all the treatment will be just a waste of resources.
Ausra, you said something very interesting, if I can interrupt you for a second.
Sure.
You said the untreated periodontitis is a risk factor.
Yes.
Is treated periodontitis a risk factor?
Well, Stefan, in general, the history of periodontitis as such is considered to be a risk factor for periodontitis. And this we know, and we have evidence that it is a risk factor. So it means that automatically the patients with a history of periodontitis, means also treated periodontitis, they are at a high risk to develop peri-implant diseases.
So
yes.
You would say yes?
Yes, definitely.
Mm-hmm.
So we need to, first of all, after we set the diagnosis, to evaluate the patient-related factors and local risk factors, and whenever needed, modify them or adjust them before we start with any treatment. First of all, the disease, peri-implant disease, has two severities. So the initial stage of the disease is mucositis. And here we are targeting the inflammation that is restricted only in peri-implant supporting soft tissue compartment. Whereas if mucositis we leave untreated or undiagnosed, the disease may further progress, and at the end what we have is peri-implantitis. So here we have not only inflammation in the soft tissues, but also progressive marginal bone loss. And whenever I will refer to the treatment of peri-implant diseases, I will also refer a couple of times to the clinical practice guidelines provided by the 18 EFP workshop on periodontology. So the whole workshop was dedicated to the treatment and prevention of peri-implant diseases. So first of all, let's start with the treatment of mucositis. So here we are treating the inflammation that is restricted in the soft tissue compartment. The standard treatment procedure would be just a standard mechanical clinic with curettes. What options we have for mucositis treatment? We have alternative options, that is, alternative treatment measures to mechanical treatment with curettes. We have also adjunctive measures. It means adjunctive measures that we combine with mechanical treatment. For instance, photodynamic therapy, local antiseptics or local antibiotics, systemic antibiotics or probiotics. Now we need to know what measures really works, what is really effective. First of all, in terms of the alternative measures to curettes, cleaning with curettes. So that would be chitosan brushes, that would be air polish with glycine powders. Those are the measures that we have evidence for. Are they better than are those measures better? What if they work better compared to cleaning with curettes? Well, according to the data that we know today, probably at the end, there's no huge difference. Whether we clean the implant side with chitosan brushes, or we use air polishing devices, or we clean the implant side with a curette. Probably at the end, and this is what the evidence shows, we will have more or less similar treatment outcome.
Ausra, coming back to that case, can I have one question?
Yes.
If you go one
Sure.
slide back? I mean, if I look at that case, also looking from a periodontist eye, I would probably also tell you, well, the mucositis is probably also due to insufficient soft tissues. So
yes, and this is
would
another.
you see an indication if you have treated the mucositis for soft tissue grafting?
Yes, Stefan, I do agree that soft tissue is, of course, an issue. And we have, I would say, sufficient data to state that absence of keratinized mucosa or reduced amount of keratinized mucosa is a factor that contributes to the onset of peri-implant disease. And if we would raise a question, so should we graft or not? Should we create keratinized mucosa in those cases or not? We have a clear answer, yes. We had a DGI Osteology Foundation consensus meeting. We came up with the conclusions with a clinical recommendation saying that implant sites with a lack of keratinized mucosa that shows recurrent mucositis lesions are the cases where we may consider performing soft tissue grafting. So it means in this particular case, whenever I resolve peri-implant mucositis lesions, I, of course, may consider soft tissue grafting.
Yeah.
So now let's move on to the adjunctive measures. And adjunctive measures would be, for instance, probiotics, systemic or local antibiotics, photodynamic therapy, chlorhexidine gel, chlorhexidine irrigation, and also patients sometimes ask, can I do at home something good to manage the disease? And those would be the mouthwashes containing chlorhexidine. So this is a summary of the measures for which we have some evidence. And again, the evidence shows, well, of course, we can use these measures. It's not that they are not working, but it appears that at the end, we will get more or less similar treatment outcome compared to just mechanical cleaning, mechanical professional removal of the biofilm. So in summary, for mucositis treatment, today appears that professional mechanical biofilm removal along with the reinforcement of the oral hygiene procedures is considered to be a standard treatment for peri-implant mucositis lesions.
Ausra, you have not been talking about pros and prosthetic reconstruction. I mean, if I look at my clinical cases where I see a mucositis, let's be clear, most of the prosthetics is insufficient. So what is your take? Should pros be renewed or do you leave these restorations on because it's also a matter of finances, of costs sometimes, right?
Yes, Stefan, unfortunately, in many cases, prosthetic reconstruction is like a local retrogenic factor that contributes to the onset of inflammation. And in many cases, we have to reconsider either modifying or renewing the reconstruction, because otherwise, if we do not eliminate the local risk factor, we can treat the implant site, but it would be just a waste of time and also finances. So it is very, very important aspect of prosthetic.
I agree.
Definitely. So what is the outcome that we want to have after mucositis treatment? The main clinical parameter for mucositis that defines mucositis is bleeding on probing. So at the end, what we want to have is, of course, absence of bleeding on probing. And the outcome, when should we assess the outcome? So we should give a time to 2 to 3 months for the healing, not 2 to 3 weeks, but 2 to 3 months. It takes time, resolution takes time. And after 2 to 3 months, if we have no bleeding on probing or not more than one side with bleeding on probing, because we need to understand that bleeding can be provoked also by the mechanical trauma. So in the current recommendations, it is written that it is recommended to have no more than one side with bleeding on probing. So one side we can tolerate. But if a resolution could not be obtained after 2 to 3 months, in the cases without resolution, we may consider performing a second session of professional cleaning. Now, let's move on to the treatment of peri-implantitis. And here we have an advanced stage of the disease, which, as I already mentioned, is mainly defined by the progressive marginal bone loss. And according to the current guidelines, the treatment of peri-implantitis should follow a stepwise approach. After we set the diagnosis, we first of all start with a non-surgical treatment. And if a resolution could not be obtained, we should consider a surgical intervention.
Ausra, is there a threshold? Because let's be honest, if you have 50% of bone loss, isn't it useless to start with non-surgical therapy? Let's be clear.
Well, Stefan, if we have an advanced disease, we will probably have also a really inflamed soft tissue compartment.
Of course, I agree. As a pre-surgery.
The management of soft tissue during the surgery, and especially if we plan to perform GBR, bone grafting procedures.
Sure.
It makes already sense to resolve the inflammation in soft tissue compartment.
No, I'm talking as an only measure.
So as an only measure, it might be really challenging just to resolve the inflammation just by non-surgical treatment. And I will also talk on when should we reevaluate the site and decide to go for the surgery. But yes, as you already said, it is quite unlikely that only by the non-surgical treatment we will manage those cases. So first of all, now we will, in terms of a non-surgical treatment of peri-implantitis, here again, we have many different options possible. We may use this mechanical cleaning with curettes. We may use heat-or-sand brushes. We may use lasers. For instance, air-Biumviac laser. We may use air polishing devices. We can use also adjunctive measures, means mechanical cleaning plus adjunctive measure. Now, let's find out what measures really works and what the current evidence shows us. First of all, in terms of the alternative measures to, it means alternative treatment protocols to cleaning just with a curette. That would be air polishing devices with glycine powder or air-Biumviac laser. And if we would take a look into the literature, we would see that we have studies showing that within the short period of time, that is within 3 to 6 months, by using alternative measures, we can obtain a high resolution in bleeding values. But those benefits, as I said, are limited only to 3 to 6 months. It means that after 1 year, there's no difference if we clean the implant site with curette or air polishing devices. Now, in terms of the adjunctive measures to mechanical cleaning, and that would be, for instance, diode laser, photodynamic therapy, probiotics, local or systemic antibiotics, and again, chlorhexidine gel, chlorhexidine chips, or mouthwashes with chlorhexidine. So this is again the summary of the measures for which we have evidence. And so far, none of a specific adjunctive measure could lead to superior treatment outcomes compared to the standard mechanical cleaning. So it means it doesn't matter, but probably if we will use curettes plus chlorhexidine, we will end up with a similar treatment outcomes like using curettes alone. So the goal of non-surgical treatment is to resolve the inflammation. So it means to switch from this initial situation to situation like that. And the ideal outcome that we would like to see following the non-surgical treatment are shallow probe in the phallus, that is ideally not deeper than 5 millimeters, no suppuration, and no more than 1 bleeding site. And those are the recommendations provided by the EFP consensus, clinical recommendations provided by the consensus. The reevaluation after non-surgical treatment should take place within 6 to 8 months. And if we see that this endpoint could not be obtained, they have to directly plan the surgical intervention. And this is just a suggested time frame, 6 to 8 weeks. In advanced cases, as you said, Stefan, I would not wait maybe 6 weeks. If we see that we need a surgical intervention, I will schedule the patient within 2 to 4 weeks for the surgery.
Yeah.
So it means that in majority of the cases, or more advanced cases, non-surgical treatment is probably not effective alone. And after we switch from the initial situation like this to situation like that, we need to plan surgical intervention. Now, in terms of a surgical intervention, so the goal is to get the access to the implant surface, to remove the granulation tissues, and to clean the implant surface. And you see, in this case, On your right side, you see also many scratches on the implant surface. So this is a consequence of a cleaning of the implant surface during the maintenance appointment. So we also need to be aware how we clean the implant site, because it's not the same as cleaning teeth. And now, after we remove the inflammatory tissues, we need to know how should we remove a biofilm from implant surface? How should we decontaminate the implant surface? And there have been so many different measures suggested over the years, and I think that if you would ask 10 colleagues how they clean the implant surface, you would probably hear 10 different recipes, because
or maybe 11,
or even 11, because everyone has their own recipe for decontamination of the implant surface. But again, here, let's find out what evidence we have, scientifically based evidence, with regards to implant surface decontamination. And here again, I come back to EFP consensus meeting, where the task of our group was to shed more light upon the efficacy of implant surface decontamination methods during the surgical treatment of peri-implantitis. And again, if we take a look into the literature, we would see that many different measures have been tested, so many different lasers, physical and mechanical treatment approaches, and unfortunately, many approaches failed to show any benefits compared to just mechanical cleaning with curettes and irrigation with physiological solution, except for one measure, and that is a titanium brush, which was shown to be more effective compared to air polishing devices or compared to cleaning with curettes alone. And this is the only measure, I would say, for which we have evidence that it functions better compared to just cleaning with a curette.
And now comes the most important question. Why do you think is so? I have the same clinical feeling. I know your work, but why?
Well, Stefan, so this is also the recommendation by the EFP, which says that we should consider using titanium brushes. This is the evidence based on the RCT.
Yeah, sure.
But I would say that, Stefan, that by using titanium brush, we perform like kind of a micro implantoplasty. Have you seen that after cleaning the implant surface, the titanium brush, it starts to shine, kind of?
Yeah.
So I would say it's like a mini micro implantoplasty.
So could we say the data for decontamination of an implant between a titanium brush and implantoplasty are the same? You understand my question?
No, I would not say. The standard implantoplasty, and we will discuss it later on, I would not consider it as a measure of decontamination.
Yeah.
Not a contamination, it is an adjunctive, I would say, I would call it as a resective measure. And the goal of implantoplasty is not to decontaminate, but to reduce the risk for reinfection after the treatment, to avoid having exposed rough implant surfaces into the oral cavity. So it is not a decontamination measure. Many call it as a decontamination measure, but I would call this as an adjunctive resective measure. But we will talk about it also a little bit more in details.
Yeah.
So now we come to the surgical treatment of peri-implantitis. And what options do we have? Basically, we have 4 options. We can go for non-reconstructive therapy, that is a simple open flap debridement. So it means we open the flap, we clean the implant surface, and we reposition the flap. We can go for resective therapy, and here I'm referring mainly to the implantoplasty. We can go for reconstructive therapy, that is, we aim to rebuild the bone, we fill the defect, or we can also go for combined treatment. Combined treatment, that is a combination of resective and reconstructive treatment. What we need to understand is that there's no single surgical approach which functions perfectly well in every clinical scenario. The treatment approach we need to decide in every clinical case individually, and let's discuss it more in details. So I think you will agree, and everyone will agree, that After we clean the defect site, we have many different defect configurations. Sometimes we have purely those typical characteristic lesions, intrabony circumferential lesions at the implant sites. Sometimes we have a purely horizontal bone loss. And let's discuss what surgical approaches we may consider in different clinical scenarios. So please take a look in this case. Here we have a purely horizontal bone loss. We do not have intrabony compartments. And in other words, it is a non-contained defect. So this defect does not have a biological potential for regeneration. So this is a case where I decided to go for open flap debridement. So I said, okay, we cannot rebuild the bone. I cleaned the implant surface with titanium brush. I repositioned the flap, and look, this patient came 6 months after the surgery. What I see as a result of a surgical treatment, I have a recession. I have exposed implant threads. At a distal implant, you see also calculus in between the threads. And if you would go here with a periodontal probe, it would start bleeding, and also you would find a suppuration. So my treatment is not successful. So what could we do different in cases like this? And in cases like this, that we have a horizontal bone loss without the regenerative potential, I would go for a surgical approach which is called as resective therapy by the means of implantoplasty. So implantoplasty may be advocated for the treatment of supracrestal non-contained peri-implant defects. And
so Ausra, just to make it clear, because you said like the titanium brush is doing a mini implantoplasty, which I like very much the term. You think in these cases it is not enough because the thread is still there, or is there still microtopography? What was the problem?
Well, Stefan, the problem is the macro geometry. So we need
the
threads. And that is the goal of implantoplasty. And it is, as I will repeat again, it's not actually a decontamination approach. I would call it as a resective measure.
So you see a difference, because that is also some people say that a little different, which is fine to discuss. You see a difference between leaving a thread on a machined implant, because let's put it like this: a titanium brush would sort of machine my implant. It's not completely correct, but let's put it like this. But you would see a difference in the long-term prognosis if you don't remove the thread in a supracrestal situation.
Stefan, for the machine surfaces, if we have the exposed thread, machined threads, I would not do any implantoplasty because it is the surface is smooth. But by using titanium brush, there's no chance that we will remove the whole macro rough surface.
Okay, get it.
So open flap debridement, as I said, showed the first case would be for me, the smooth surfaces, the implants with non-modified surfaces would be the only indication for simple open flap debridement surgery.
Okay, I get it. So let's make it clear. There is still a difference in roughness when you work with a titanium brush compared to a machined implant, because this is sometimes what you hear, that a titanium brush is sort of machining back the implant.
Yes, but it's not equal to implantoplasty at the implants with rough surfaces.
Thanks. Good statement. Yeah.
So let's move on to a case like this. We have advanced lesions, and later on we can discuss the case where we decide to go for treatment or explantation. But here again, we have advanced lesions, non-contained lesions, and if you want to keep those implants, I would go for the implantoplasty. What options do we have? What we can do is a reconstructive therapy. And for the reconstructive therapy, we need a specific defect configuration. To go for a bone reconstruction, we need to have intrabony defects supported by 3 or 4 walls, and the depth of a defect should be at least 3 millimeters. So it means we cannot reconstruct in every case. We need to have a defect configuration that fulfills this criteria. A case like this. So it means we decontaminate the implant surface, then we use a bone filler material. We may use a membrane or not. So this is also a question, I would say this is still an open question if we do necessarily need to place a membrane or not. But so we go for bone reconstruction. In this case, I use a GBR approach, and I would say there's still a tendency that whenever we use the particulated bone filler particles, the GBR-supported approaches, there's a tendency showing better treatment outcomes compared to the non-GBR-supported approaches. And in case like this, again, a perfect case to go for a reconstructive therapy. And in this case, I use a volume-stabilized material.
Ausra, if I see these pictures, and I always ask myself, if I fill defect with DBVM material, autologous graft, whatever, what can I expect? I mean, I always ask this myself as a periodontist. You're a periodontist yourself, and we augment cases, we use animal matrix derivative, and we have human histology that we know it's going to be a regeneration in teeth. Will that be around implants too? So what can I expect there in this border area, in this infracrestal area?
Yes,
after
Stefan,
I feel
it's a very good question. Do we get a reosseointegration or not?
Yeah.
Because that would be the goal, to establish reosseointegration. Well, to be sure, if we have a reosseointegration, we need to do a histology. So from the clinical perspective, there's no chance to do a histology. But I would say from the clinical perspective is the resolution of inflammation. Yeah. We can obtain a radiograph to see if a defect fill was obtained radiographically or not. Yeah. Or the reosseointegration, an outcome as such, for me, does not make much sense. Because this is nothing that we can assess clinically. Yeah,
no, I agree with you, but always if I fill in these granules, I always think what this is going to do. Yeah, is this going to just hold up everything? So what do you think is going to happen there? Or you have histologies there, probably from your group, from Frank's group. Is there going to be like a long epithelium on the implant? Do we know that? What's going to happen in the border zone between?
It is not the epithelium, but whenever you re-enter the site, you see hard tissue. We do not know if it's really reosseointegration or not.
And do we have like histological data from animal studies? What's going to happen?
The animal studies, there are studies showing that we can obtain reosseointegration.
Oh, okay.
So, but as I said, from the clinical perspective, if someone says my goal is to get the reosseointegration, well, from the clinical perspective, you never know.
I get you.
So another case, and I would say more challenging case, and this is the case, Stefan, similar case that you showed to me, and this is a combined defect. Combined, it means that we lost the facial bone wall here, but all around the implant, we have a circumferential defect. So what we may consider using in such cases is a combined treatment. So we use implantoplasty at the implant sites that are outside of the bony envelope, and we use the reconstructive therapy at the intrabony compartment. And this is called as a combined treatment. Look at the case like this. Of course, we know that implant success starts with the right implant positioning. If you take a look at the positioning of this implant, it is far beyond the mucogingival junction. So it is far from being ideal. We raise the flap. We see advanced lesion, particularly at the implant in region 4-2. And again, what we see is a combined defect. We have a horizontal bone loss, but all around the implant, we also have a circumferential defect. So what we can do here, we can do an implantoplasty at the implant site that is out of the bony envelope, not supported by the bone, and intrabony compartment we fill with a bone substitute material.
Ausra, I'm always not sure in these cases. I mean, I'll do like you, leave the pros on. Sometimes you have a slight supracrestal defect on the lingual aspect too, right?
Yes.
So at what point would you also consider implantoplasty on the lingual side? Because this is so difficult.
It is challenging.
I sometimes have the feeling I leave it more rough than it was.
It is challenging, and if you do not have a chance to remove a prosthetic restoration on a lingual aspect, it is really, really challenging to get the access to the implant surface. But ideally, we would perform implantoplasty at the supracrestal compartment as well, ideally, and also the dehiscence part of a defect.
So but already, if it's a millimeter supracrestal compartment, you would consider implantoplasty? I
would consider implantoplasty. Of course, there are cases where we need to make compromises, And not in every case we have a chance to remove a prosthetic restoration.
Yeah. Mm-hmm.
And but ideally we would perform implantoplasty also at the supracrestal compartment. A case like this, also a very typical case, and I have to admit that majority of the cases that I see are indeed the combined defects. So big defects, we also have a horizontal bone loss or a dehiscence type defect. So this is the case that I showed previously. So we see many scratches on the implant surface as a consequence of the maintenance appointment. So what I did implantoplasty, and in the intrabony compartment, I performed the reconstructive therapy. Again, very similar case. You see the implant in the region 4-5. We have a horizontal bone loss. So this is the case that I decided to go for implantoplasty, and here we have a combined defect. So the intrabony compartment, I leave the implant surface not modified, but at the buccal aspect where we have a dehiscence type defect, I do an implantoplasty. I go for reconstructive therapy at the intrabony compartment, and this is the closure of a flap. Now,
and just to make it clear, the infracrestal or infrabony compartment is just cleaned with the titanium brush, correct?
Yes, the intrabony. So we start always with the cleaning with titanium brush or whatever measures you're working with. The implantoplasty comes on top.
Okay.
And on top, it means only at the non-contained compartment.
Sure.
A more challenging case, anesthetic area. So you see here we have also probably not an ideal implant positioning. And this is the defects that we have. So again, combined defects, missing facial bone wall, but all around on the lingual, on the palatal aspect, we have an intrabony compartment. So in this case, I also used a combined treatment.
Ausra, sorry, I have so many questions because it's so interesting, your lecture. That's a good sign, because then I always ask so many questions because it's so interesting. This is a clinical problem I also encounter. I have the feeling now, if I look at your case, you did the implantoplasty a little bit too coronal. You understood what I mean? Because there are still threads in a supracrestal compartment. So how far apical do you go? This is also a clinical problem I sometimes have. I mean, in this case of this, what is this, a bicuspid? You left some of the threads, which are supracrestal on the buccal side, you left them without an implantoplasty. You see my point?
This is a really very good point. This is a very good point. Well, of course, we can also continue the implantoplasty to that point, and that would be not a problem, not at all. And even if I would, now I look at this case, I also raised the question, okay, I could have maybe extended more apically. But I use also a reconstructive therapy on top. And but this is a very good point, because I would probably, if I would do again this case, I would also extend the implantoplasty at least up to here.
You think it would be necessary, right? Because I always have this problem, because I think then I tell myself I will overgraft a little bit.
Yeah, so this is what I did in this case. I overgrafted a little bit. But for me, the most important aspect is here. The aspect I will have exposed implant surface as a consequence of recession. Okay. Because as I said, this is not a decontamination approach. This is the measure to reduce the reinfection of the implant site.
Get you.
At a later time point. But it is very valid point, really very, very valid point, that the implantoplasty would, of course, make sense also to extend it more apically.
Yeah, but you could also say, maybe this is then so far apically, you have a clean implant surface. I mean, why would you get reinfection so far apically, right?
Exactly. So for me, the most important is a more coronal aspect.
Yeah, very good point.
Yes, very good. Really very valid point. And this is the result that I have. A consequence of surgical treatment, and also in advanced lesions, we always have a soft tissue recession. For some patients, that might be a disaster from the aesthetic point of view. For these patients, we had a low smile line, so it was not a huge issue. But if we would have a high smile line, well, that would be a compromising case. And I would say that not only the resolution of inflammation, but also the aesthetic outcome is a very important aspect. Let's take a look at another case. Again, aesthetic area. I raise the flap, and this is the defect that I have. It is a non-contained defect. So I have one wall defect where I have no chance to reconstruct the bone, but I'm working in aesthetically demanding area. I'm afraid of a recession because we know that it doesn't matter. Every time we raise a flap, we have a soft tissue recession. So what I did, in this case, I decided to go for a soft tissue grafting to increase the soft tissue thickness, the soft tissue volume, to maintain soft tissue height. And this is the outcome that I have 12 months following a treatment. So in aesthetically demanding areas, I would indeed consider performing soft tissue grafting. Also in the cases where we use reconstructive treatment, and on top, I would consider soft tissue grafting. Now, the outcome of a surgical treatment. The outcome should be assessed 6 months following the treatment. So it is recommended within the first 6 months, particularly if you perform the reconstructive therapy, to not probe the implant site. We can just gently check how is the outcome, if it's bleeding, if we have suppuration, but to not really probe deeply to the bottom of the defect with a probe. After 6 months is a time point to assess a treatment outcome. And what we want to have is, first of all, absence of inflammation. So it means no suppuration, no bleeding on probing. Ideally, shallow probing the values. But as I said, also soft tissue recession is an outcome that we need to account for, and also explain the patients prior to the start of a treatment that soft tissue recession is something that we might expect, and that we might have exposure of a metal surface into the oral cavity, and particularly in aesthetically demanding areas. And this is the case. Stefan, what would you do in this case?
For me, to be honest, clinically,
Yes.
50% of bone loss is for me.
What would you do in this case?
Is a little bit of a cutoff value. I mean, I also have a supracrestal compartment with it. I am not sure if I would keep this implant, to be honest with you, because it's more than 50% of bone loss. I hope you kept it and can show me a great result, but I would have probably removed it.
Yes. Stefan, I completely agree with you, because this is the case where we would say, okay, we know that if the implant, more than half of an implant is not in the bone, the treatment outcome, the success is reduced, considerably reduced. And keeping in mind that, I was discussing with the patient. I was also suggesting, well, that maybe we can give it a try, but the treatment success, well, the rates are reduced, and the patient.
So Ausra, there's a question from a spectator. Use galvosurge.
Yeah, this is the question that I was expecting. Well, to be honest, if you would read any clinical guidelines, also the guidelines by EFP, by EAO, you will nowhere find a galvosurge as a decontamination measure. Nowhere. It's mentioned nowhere. Why? The thing is that we do not have any clinical data, no clinical studies, no, or let's say high quality clinical study, not a single. So therefore, you will not find this measure in any clinical recommendations. So this is, I would say, the main limitation, that we still need data, but I'm so sure that in the next time, in the nearest time, we will have some evidence, and I'm very much also looking forward to that. But so far, I cannot tell you much.
What is your personal thinking? Have you used it?
I cannot tell, because I have never tried it. We do not have this approach, and we don't have this equipment. I would be curious about trying that, but from my personal practice, I cannot tell you, because I never used that. But I'm really, really looking forward to the evidence.
I mean, I would just, my 50 cent, I would agree with the colleague. It could be an option, but I think as we also have a supracrestal compartment, we need to think twice how to manage that supracrestal compartment. So probably has to be a galvosurge combined with implantoplasty, which might be critical. So it is a critical case anyway. So show us what you did.
Yeah, but now just I think just recently I saw a paper just recently published by Alberto Monge, and he did some case series that he compared the cleaning with implant surface titanium brush plus galvosurge and titanium brush plus peroxide. And there was no difference between the two approaches. But of course, he used titanium brushes in both of the cases. So, but yeah, let's see what the future shows. I'm also really excited, and yeah, let's see what the future brings.
Yeah.
Let's come back to that case. And I have to be honest, I was also discussing with the patient, and we were discussing many different scenarios. But the patient said, please do everything. Let's try to do everything to keep my implant in place. And I said, okay, let's do that. So we started with a non-surgical treatment, and after 3 weeks, I scheduled the patient for the surgical treatment. But look what I found. Do you see here? And you also, that is probably also the reason why this patient, quite in a short period of time, developed such advanced lesion.
A fracture?
The fracture of the implant, and that is an absolute indication for implant removal. So what I wanted to show by this case that there are no particular thresholds as to when we should remove the implant and as to what threshold we should keep the implant. In every case, we need to make a decision individually. And I tell you from my personal experience, very, very frequently patients say, please do everything to keep my implant in place. So in this case, unfortunately, we had to remove the implant because this is an absolute indication. Implant fracture is an absolute indication to remove the implant. So we performed the soft tissue, the hard tissue grafting, and we prepared the site for the second round. Now we are waiting for the healing, and after 4 months, I will go for the second implant placement. And coming back to that question, so as to whether we should remove the implant or keep the implant, well, I want to make one point, very interesting point, quite clear that, and this is the evidence that we have, but every repeated implant placement at the same area where we remove the implant due to peri-implantitis, with every repeated attempt to place the implant, we had reduced success rates. So if we try for the second time to place the implant, our success rates are 77%. If we try to place a third implant at the same implant site, the success is reduced. And if we do a fourth attempt, so the third attempt after explantation, the success rates are 50%. So whenever we decide to remove the implant, we also need to keep in mind that there's no guarantee that this repeated implant placement will be a success. So now just summarize my presentation, I will refer to the clinical recommendations provided by the EAO position paper. First of all, mucositis treatment, mechanical professional biofilm removal, along with the reinforcement of oral hygiene is a standard treatment for mucositis lesions. For peri-implantitis treatment, we always start with non-surgical treatment, and if not sufficient, we start with a surgical treatment. Surgical intervention, we should plan if a disease resolution could not be obtained, and disease resolution is defined by combination criteria, that is bleeding not more when one side, no suppuration, and probing depth values not deeper than 5 millimeters. Now, in terms of surgical treatment, the adjunctive reconstructive measures may be beneficial in enhancing radiographic fill of a defect and in maintaining soft tissue levels. And those aspects, in particular, the maintenance of tissue level, is very important aesthetically demanding area. So if we talk about the resolution of inflammation, I would say there's still debates whether placement of a bone filler material will help us to resolve the inflammation. So it is not so much about the resolution of inflammation, but it is about the maintenance of soft tissue height. Because if we graft the bone, we increase the hard tissue dimensions, and the bone sets the tone for the soft tissue. So it makes sense that by performing hard tissue grafting, we also have better support for the soft tissues. And finally, for the surgical treatment outcome should be assessed, as I already mentioned, not earlier than 6 months after the treatment. And again, what we want to have is a disease resolution. If disease resolution could not be obtained, we may consider retreatment or implant removal. And the final slide, we see that adjunctive systemic antibiotics along with a surgical treatment does not seem to improve a clinical outcome, and also in line to the current clinical guidelines, systemic antibiotics are not recommended as a part of a surgical treatment of peri-implantitis, or at least not for the routine prescription. The regular supportive therapy, it is a must after we complete the surgical treatment. So in order to maintain this outcome that we have, it is very, very important to enroll the patients in a supportive therapy. And if you see how frequent should we see our patients, I would say that within the first year, we may see our patients every 3 months. And at a later time point, if the patient, according to the risk profile of a patient, at least 2 times per year, we should see our patients, so every 6 months. But if a patient is a smoker or has a periodontitis, poorly controlled periodontitis, we have also patients that come every 2 to 3 months for the maintenance appointments. And in the presence of advanced bone loss at the implants that are not strategically important, we may directly consider implant removal instead of a treatment. Yeah,
Ausra.
and this is, yes.
Yeah, sorry, you're ending.
Yes, that was the last slide that I prepared according to the, as I said, the current EAO position paper.
Thank you. Ausra, that was amazing. I applaud you. People are applauding you also from the audience. Great, wonderful. I really, really learned a lot. We still have some more questions from people, and I think some of them are interesting. People are talking about titanium particles. Maybe 2 aspects of this question. What do you think as an etiological factor? You know, the old discussion. And the second thing is, are you concerned about titanium particles following implantoplasty?
Yes. So first of all, in terms of etiology. So there's a hypothesis that titanium is a problem. Well, I would doubt, because if it's the titanium, why do they have peri-implantitis lesions also at zirconia implants? They have a similar lesion, circumferential intrabony lesions at zirconia implants. So is it really all about the titanium? I would probably leave it as an open question, but and with regards to the titanium particles that we always have after implantoplasty. So of course, we need to remove the titanium particles as good as possible, and it is challenging and it takes time. But I would say today we do not have a single clinical data that would show that those titanium particles after implantoplasty would maintain inflammation in the surrounding tissues. We have histological slides from a preclinical study showing that, yes, of course, we always have remaining titanium particles in a soft tissue compartment, that they are encapsulated in a connective tissues.
But just as a clinical handle, how do you do it after you implantoplasty? You scrape over it with the elevator?
Tricks and tips. It's just meticulous rinsing this physiological solution, and nothing particular, nothing special.
I sometimes have the feeling if you induce bleeding a little bit, it's also washing it away, but I agree.
Yeah, so I would not recommend any specific measure to remove the titanium, but of course it takes time. You have to be really, really meticulous, because if you just leave it as it is, there might be a risk for type 2 discoloration of a tissue. So this is something that we really do not want to have.
Ausra, there's a question, but I think we already addressed that. There was a question, how do you clean the subcrestal region? I think we already addressed that, but you want to maybe stress that again?
Subcrestal surface, if it is an implant with a modified surface, I would go for implantoplasty, the smoothing of the rough surfaces.
No, it is about a subcrestal area. So I think the infracrestal, he's talking about
the I would not modify the surface. I would just decontaminate. And I said what I use, and also what the evidence shows, titanium brush. I would use only titanium brush.
There's also two questions, but I think the answer is quite quickly. Do we have any evidence about hypochlorite gel during peri-implant mucositis or also during peri-implantitis treatment? And also, is there any evidence for hyaluronic acid in these two aspects?
For this question. Well, in terms of the evidence, there's not not much evidence. I think there are a couple of studies will show very shortly. But in terms of evidence, I don't think that we have. For periodontitis treatment, we have really nice data coming from the groups that are working with hyaluronic acid. And this is something that also I'm looking forward in the future for the treatment of peri-implant diseases, to use the same concept. We have evidence for periodontitis treatment, the same concept to probably adapt for treating peri-implant diseases. But in terms of the evidence, there's still something that will, I'm sure, show up in the next time.
I'm sure your sister is working on this.
Yes, indeed.
Hello, greetings to Igle.
I'm super excited with this topic, and so Igle showed really nice data for using this concept for periodontitis treatment, and yeah, I'm looking for the future data.
Ausra, the last question is always for me because, and I have a very interesting question. We're already a little bit time-wise, so we may make a short answer. There's data coming from your university that subcrestally placed implants may be a risk factor if it's periodontitis patients. You know, Catherine published this. I asked Thomas the same question 4 weeks ago, and he said, no. What is your take?
Yeah.
Do you see that? I mean, your clinic is quite famous for one implant system. Probably this is from data from this system. Do you see this also, or is this not the case?
Well, Stefan, it's really good question. And to answer to this question, I will refer it again to like evidence or more like clinical recommendations provided by the EFP. And if you would read the first section, prevention of peri-implant diseases, there's the first section that starts with proper implant placement. Then there's a sentence saying, please avoid a deep implant placement that is a deep tunnel. And what is the rationale behind that? It is not about the onset of inflammation that the deep implant placement per se may increase the risk for peri-implant disease. No. But whenever you have an inflammation in the presence of a deep tunnel, it is way more harder to treat the implant that has a deep tunnel compared to the implant that has a shallow tunnel. So therefore, the EFP came up with a recommendation, avoid a deep implant placement. And that is the rationale behind. It is not a risk factor per se, but whenever you have a problem, it is way more harder to solve it.
I agree with you. And I think it's a very, very clever answer you gave. And in particular, in periodontitis patients, I actually do avoid this.
Yeah.
Ausra, that was amazing. We are already over time, but this is a good sign because we discussed so much. I hope I interrupted you not too many times. I was not unpolite, but it was so interesting what you presented, and people are applauding you. You can read it later in the YouTube chat. Great presentation, congratulations, whatever. I would love to tell the audience that we have an EAO annual congress. Probably you're going to meet Ausra also there. It's going to be in Milano. It's going to be on 25th, 26th of October, or 24th to 26th of October. Tomorrow is the last day for the early bird registration. So if you want to go there a little bit for less fee, tomorrow is the last date. Please use it. With this, Ausra, I would like to thank you for your presentation, for making this possible on behalf of the EAO. It was amazing to have you. It was a great pleasure. People all applauding you all around. And I know you had a horrible travel day, but you managed it so well. So congratulations to your work.
Thank you so much.
Congratulations to
Thank
your
you so much.
presentation. I say ciao, ciao to Frankfurt and ciao, ciao all around the world, and see you guys in Milano. Ciao,
Yes,
Ausra. Ciao,
Milano. Bye
everyone.
bye.
Ciao, ciao.
Bye.